Hello, I'm again Giacomo Grasselli from the University of Milan, and we have discussed before the indications for ECMO in patients with ARDS. We now want to discuss how to wean the patients from VV-ECMO. My disclosures, and I would like to start with this sentence by Robert Bartlett, one of the fathers of ECMO, that says that ECMO is always started one day too late and weaned one day too early, which underlines the problem of weaning. So it's always very difficult to understand when it's the right moment to wean the patients from the extracorporeal support. So why is this so difficult? Well, first of all, because again, it's difficult to understand when is the correct timing for the disconnection. We do not have definite criteria. Most people follow local protocols or some guidelines, but mostly this is based on the personal experience of the clinician. So we can identify 4 scenarios. Well, the first one I called conventional scenario. So what happens more frequently. So first we wean the patient from ECMO and then from the mechanical ventilator. The second scenario is the emergency ECMO discontinuation. The third one is the opposite of the first one. So we decide to wean the patient first from the ventilator and then from the ECMO machine. And the last and more unfortunate scenario is when we are forced to discontinue the ECMO support because we find that it is futile to continue to maintain the patient on ECMO. So let's discuss the first and more frequent conventional scenario. So what happens is that as the lung function improves, as the function of the patient's lung improves, the ECMO support is gradually reduced. So we reduce blood flow, gas flow, FiO2, and we can use ECMO to facilitate the switch from controlled mechanical ventilation and any assisted mode of ventilation, for example, pressure support ventilation, and then so the patient is weaned off ECMO, and after that the patient is weaned from the ventilator and ultimately extubated. So the crucial step here is to understand whether a patient is ready or not for weaning. And then once we have assessed the readiness for weaning, then we have to do a trial of ECMO discontinuation. So how do we assess the readiness of a patient? It's similar to what we do, for example, during weaning from mechanical ventilation, okay? So first of all, we need to understand if the patient is ready to be weaned. So the patient must be hemodynamically stable. This is very important. We need to demonstrate that the respiratory function of the patient's lung has improved. And this, we can judge it by the increase in the contribution of the native lung to systemic oxygenation. According to the ELSO guidelines, the oxygen consumption of the native lung must be more than 50% of the total oxygen consumption. We always monitor respiratory mechanics, and so if, for example, the lungs were very stiff at ECMO connections, then we judge that the patient may be ready to be weaned when the compliance of the respiratory system has significantly increased. And of course, we want to see an improvement in gas exchange and the intrapulmonary gas shunt fraction. So this is an example of a patient that has been successfully weaned. You can see here, this is the baseline situation. Then we stop the gas flow. So we stop the ventilation of the membrane lung. So, and of course, we will see an increase in minute ventilation. But as you can see here, basically no significant increase in blood pressure, heart rate, and so the patient, let's say, remains relatively stable after ECMO discontinuation. That's another different example. So we stop the ventilation of the membrane lung, and immediately you can see a significant increase in heart rate, in systolic blood pressure, a decrease in oxygen saturation, and a major increase in minute ventilation. That means that this patient is probably not able to tolerate spontaneous breathing without the ECMO support. And so in this case, we judge that the patient has failed the trial and we restart the ECMO machine. So if the patient succeeds the assessment of readiness, then we do a trial of ECMO. So what is very, very important to remind is that veno-venous ECMO does not give any hemodynamic support. So basically, you can do a trial of VV-ECMO without reducing the extracorporeal blood flow. You don't need to reduce or to stop the blood flow, which is completely different from veno-arterial ECMO. Okay, so we don't stop the blood flow, so we don't have to change the heparin dose. Then we adjust the ventilator settings to values that we would deem acceptable of ECMO. So acceptable FiO2 and the level of pressure support, for example. And then we turn off the sweep gas. So we stop the ventilation of the membrane lung. And what is very important to remember, is that we have also to clamp the gas tubes, because if you don't clamp the gas tubes and you just put to zero the node of the flow meter, then there might be still some air flowing through the circuit. Okay, so we have to turn off the sweep gas flow, and the oxygen will be fully consumed in the circuit in about 20 minutes. We don't know how long should be the trial, so the more unstable is the patient, the more doubtful you are about the success of the trial of ECMO, the longer you should keep the trial. Sometimes we keep the patients of ECMO for, let's say, the entire night. And of course, during the trial of ECMO, we need to closely monitor the patients. So hemodynamics, the mixed venous or central venous oxygen saturation, which is a proxy of the adequacy of oxygen delivery without ECMO, and obviously the gas exchange and the respiratory pattern of the patient. So there are no established guidelines. These are the guidelines of the Karolinska Institute. So they keep the gas off for at least 4 hours, and they set the ventilator to pressure support with a relatively low level of PEEP and FiO2, and support between 10 and 15 centimeter of water, and then the patient is disconnected if after 4 hours with these ventilator settings and off ECMO, his respiratory pattern, gas exchange, and hemodynamics are acceptable. Then we get to the point of decannulation. So if the patient remains stable, then we have to remove the cannulae. So some authors propose to leave the cannula in place for a few hours to allow eventual recannulation of the patient, so reinstitution of the ECMO if the patient conditions deteriorates. And it is known that the venous cannula can be left in place for up to 48 hours if they're flushed with a drip of heparinized solution. But I have to tell you that this is not, for example, our common practice. We do it very, very rarely. So when we think that the patient is ready to be weaned, we do the trial of ECMO, and if the patient succeeds the trial, then we remove the cannula. The second scenario is the emergent discontinuation of ECMO, which usually happens because either the patient has uncontrolled bleeding, or we think that the patient has sepsis stemming from infection of the cannula. So in this case, the patient is disconnected from ECMO usually when he is still on controlled mechanical ventilation, or if he was on pressure support, is returned to controlled ventilation if assisted ventilation cannot be tolerated after the ECMO stop. So the patient is usually decannulated while still on controlled mechanical ventilation. Then there is what I call the unconventional scenario, so which is when we have patients that we want to extubate as soon as possible to avoid the complications of prolonged intubation and prolonged invasive mechanical ventilation. So classical examples are immunocompromised patients or patients with status asthmaticus. So in this case, sometimes we decide to wean the patient from the ventilator. So to extubate the patient while they are still on ECMO, and then we keep them on awake ECMO. That's another scenario that sometimes happens in selected patients. So let's take a look of the technique of the cannulation. So we have to reduce or to stop the anticoagulants. This is very important, especially for arterial cannula. Then what we do is that we perform purse string sutures around the cannula insertion sites. Then we clamp the cannula, stop the pump, remove the cannula, allowing a small blood leakage, and then we tighten the sutures to avoid further blood leakage from the cannula insertion sites. This is important, especially when removing a jugular cannula in a patient who is spontaneously breathing. So in a patient who has significant inspiratory efforts, so significant decreases in intrathoracic pressure during inspiration, then there is the risk of air suction through the cannula insertion site. And so this is clearly seen, for example, in this picture taken from an echo, from an ultrasound of the heart of a patient, where you can see the bubbles in the right ventricle. So this is air entering in the circulation, sucked into the circulation from the cannula insertion site. So how can we avoid this? Well, we can ask the patient to perform a Valsalva maneuver, and we can do an expiratory hold at the ventilator at the time of cannula removal. So in order to avoid swing of intrathoracic pressure that would allow the entrance of air from the cannula site insertion. So this is important. Once the cannula have been removed, we perform a manual compression of the insertion sites, and this should be long enough. I would say 20 minutes for venous cannula and at least 30 minutes for arterial cannula. Then we have to check on the patients very strictly, especially the groin, for the risk of hematoma formation. If we have disconnected the patient from VV-ECMO, then we need to check the limb perfusion distal to the site of the arterial cannula, because you know that the main risk is ischemia of the heart. And then what we do in every patient after ECMO discontinuation, after the cannulation, we perform a follow-up vascular ultrasound to check for eventual venous thrombosis in the site of insertion of the cannula. And this is my last slide, and I want to share with you a paper that we published recently with my group on the incidence of catheter-related thrombosis. So this is not only ECMO patients, but every patient in the ICU with at least one intravascular device. So we perform routine ultrasound of the vessel insertion sites in 203 patients for a total of 357 catheters. And we found quite high incidence of catheter-related thrombosis, around 14% of the patients. But we have to say that in the vast majority of the cases, the thrombosis was partial and it was always asymptomatic. The incidence was higher for pulmonary artery catheters, for catheters positioned on the left side and with internal jugular cannulation. While, a little bit surprisingly, ECMO catheters and obese patients seem to have a protective effect. So I don't really have an explanation for this, especially for obesity, while for ECMO, when we may expect a lower than expected incidence of catheter-related thrombosis because the patients during ECMO are fully anticoagulated, and this certainly decreases the risk of thrombosis. But still, our common clinical practice, we routinely perform an ultrasound, a vessel ultrasound after decannulation of ECMO patients, just to make sure that they do not have any residual thrombosis of the vessel where the cannula were inserted. So thank you very much for your attention, and enjoy the rest of the Congress. Thanks.